afternoon and welcome. My name is Marissa Lozano. I'm the Director of Community Education here at the Muscular Dystrophy Association. Thank you for joining us today. Today's session is part one of our gene therapy series, which is focused on advancements and considerations in gene therapy across neuromuscular diseases. We hope that this series will provide the patient community with a great understanding of the topic and will empower you to make informed decisions about your care or your loved one's care. Spanish language interpretation is available for this session. We are putting a link in the chat and that you'll just click on the link. Once you click on it, you'll select your preferred language. You may need to click the enable audio button. And from there, you can mute or lower the audio in WebEx to avoid a double audio. Technical support's also available. Pedro from Boost Lingo is available in the chat should you need to reach out and get any help from him. And we do want to thank our interpreters from Boost Lingo for being here today. All right. For nearly 75 years, MDA has led the way in funding research to accelerate the development of new treatments and expanding access to care and clinical trials through our care center network and advocating for access and inclusion for the neuromuscular disease community. MDA delivers its mission through many different ways, through research, access to care, advocacy, education, recreation, and engagement. Since its inception, we've invested more than $1 billion in neuromuscular disease research. And more specific to this topic today, we've invested $125 million in the development of gene therapy for neuromuscular diseases over the past 2 decades. With new gene therapy drug approvals in the pipeline, where MDA is here to facilitate access and to provide support and education to the neuromuscular disease community. All right, it is now my pleasure to introduce today's speakers. Dr. Craig Zaidman is board certified in clinical neurophysiology and neurology and is an associate professor of neurology and pediatrics at Washington University School of Medicine in St. Louis. Natalie Goedeker received her doctorate degree in nursing practice. She's currently a pediatric nurse practitioner in neuromuscular medicine at Washington University School of Medicine. Both Dr. Zaidman and Dr. Goedeker provide direct patient care to the neuromuscular community and are heavily involved in gene therapy trials. Thank you both for being here today. I will now go ahead and turn the time over to you.
Thank you, Marissa.
Thanks, Marissa.
For having us.
Thanks to the MDA for inviting us. And Marissa, you've been great in getting this organized and calling us by our first names all the way along. Because Natalie pronounces her last name Goedeker and I pronounce mine Zaidman. And I really appreciate that informal, history we've had together.
I am so sorry. We will rectify that next time. Thank you. Thank you for being here and for also just being so personable and easy to work with. So we appreciate it, and we'll let you pull your slides up and we'll get everything going.
Yeah, can you see it? Can you see our slides?
We can't.
Oh, no.
You cannot. Okay. Right. How about now?
Now we can. You are good to go.
Want to start, Nat? You want to say hi to everybody?
Yeah, I mean, I think Marissa gave us a nice introduction. We can briefly talk about what we do. Yeah.
Sure. Introduce yourself.
Okay, so we both work at Washington University in St. Louis, and in the neuromuscular division, we both take care of children. And I take care of children with Duchenne muscular dystrophy and other neuromuscular disorders in our clinic, and then also work on our clinical trials team, helping to care for the patients that enroll in our trials.
And Natalie and I are both co-directors of the Pediatric Neuromuscular Research Group that we have here at Washington University. And we're really excited to be able to talk about these now FDA-approved therapies, many of which we were in the clinical trials for. We're going to focus on Duchenne muscular dystrophy. This whole hour is going to be about drugs for Duchenne muscular dystrophy. If you are here with another interest or another diagnosis, we will do our best to get to some of those questions in the chat. But I know there's going to be more talks that the MDA has planned for that. So I just wanted to let everybody know that right off the bat. Ready, Nat?
Yep. Okay, so this is just kind of a setup that shows what Dr. Zaidman and I are seeing more and more often in clinic. So we may see two brothers with Duchenne muscular dystrophy come to our clinic with an exon 52 deletion. We're going to talk later about why that specific mutation is important for their care. But one is a 4-year-old, so a little guy, but he is starting to show some symptoms. He's not yet on steroids. And his brother is a teenager. He's 17, and he is in a wheelchair. And so mom, dad, and older brother, who's 17, he's starting to make some decisions for himself. They're starting to wonder about all these new medicines that they're hearing about. They're reading some of the family message boards and are wondering about this thing called gene therapy and if both boys can get it. But they've also just generally heard that there's some other new medicines for DMD and they want to talk about it. Both boys are candidates for what's called exon skipping medications. And they both were actually already tested for antibodies to this thing here called to AAV-RH74 actually. And both are negative. And we're also going to talk about why that is important in a bit. So they want to know what should they do and what guidance can we give them. So the reason why, when we were asked to give this talk, we decided to focus on Duchenne muscular dystrophy in particular is this very exciting slide, which shows all of the medications that have been approved specific to this disease just in the last 10 years. And you can see in the last year alone, there are 3 new medications, Agamree, Elevidys, and Duvizat. And so since those are the newest ones, we're going to focus on that. But this just kind of shows that there's been lots of research and lots of has gone into this disease in the last decade or so.
Pretty exciting.
Pretty exciting, yes.
Yeah, pretty exciting.
So briefly to review Duchenne muscular dystrophy and what causes it. So we have lots and lots of these things called genes in our bodies, and they contain basically letter coding that tells the body how to make different proteins. And so the gene that we're talking about when we talk about Duchenne muscular dystrophy or DMD is the DMD gene, which contains the letter coding to make the dystrophin protein. That's a protein that lives in the membrane outside of the muscle cell or muscle fiber that helps protect that outer membrane of the muscle as we're using our muscles every day. Exercising, just moving about, helps protect the muscles when they undergo everyday kind of damage. The DMD gene, it's the largest gene in the body, and that's relevant when we talk about how we can treat this disease. And so without this dystrophin protein, when there's a problem or mutation with the DMD gene, enough of the dystrophin protein or the right dystrophin protein doesn't get made, and the muscle cells get damaged and they eventually die off and they're replaced with this kind of fibrous scar tissue and they get replaced with fat. And there's lots of inflammation that happens as the body's trying to kind of clean up the damage that's ongoing. In Duchenne muscular dystrophy, the children make very little to no dystrophin protein. And then in a milder form of muscular dystrophy called Becker, the boys and young men still have a mutation on the DMD gene, but they're able to make a shortened form of the protein that still functions somewhat in their muscle cells.
Yeah, this dystrophin protein is real important. It connects the parts of the cell that are shortening to make the muscle shorten with the outside part of the muscle fiber, actually not the cell, the muscle fiber. And it kind of works like a spring so that when the muscle fiber contracts, it sort of helps blunt the force so that it doesn't tear the kind of lining of the muscle fiber or tear against the outside lining around it, the infrastructure around the muscle fiber.
So we put together a few current approaches to treating DMD. There actually are more than these, but we're going to focus on talking about these ones today. So first one is just reducing that inflammation that I mentioned that happens in the process of the body cleaning up what's happening as the muscle cells are undergoing stress and dying off. And the way that we do that now is through steroids, and we have actually 3 different options for steroid medications that we can use. Another potential way to treat DMD is reducing the fibrosis that can happen in the muscles when the healthy muscles kind of get replaced with that fibrosis and fat. And that potentially what can help that is a new medication called Duvizet. And then getting more at the root cause of DMD, which is that there's not dystrophin protein being made. These medications that do this thing called exon skipping, there's 4 approved medications for that target different genetic mutations. And then gene transfer therapy, which is Elevidys, and that's kind of going to be what we're going to talk about in the second half of this talk.
Yeah, we'll try and focus on Elevidys because we guessed that was going to be a major interest for the community, but we want to start with what we know the most about.
So what we know the most about are using steroids in Duchenne muscular dystrophy. And we know there have been a couple bigger studies and lots of smaller studies looking at how steroids can help all these different things in Duchenne muscular dystrophy, from preserving the ability to walk longer. We know that using steroids in young patients helps boys walk for about 2 or maybe 3 years longer than boys who don't get steroids, all the way to potentially preserving heart function, breathing function, maybe even what's not on here is delaying onset of scoliosis. And so we have the most data for these steroid medications, and we're going to talk a little bit more detail about each one of them.
In some of our graphics, we borrowed from other sites, and you can see we've listed those references because we don't want to crib anything. So is it me now, right?
It's you now, yeah.
Yay.
Yeah.
So I'm going to talk about deflazacort, or Emflaza, and this is the steroid that came along after many, many years of using prednisone or prednisolone. First approved in the United States in 2017, and I would guess a lot of you that are listening in are familiar with this. It's FDA approved for boys age 2 years and older. It comes in a tablet and a suspension. And contraindications, that means reasons not to give it, they're really just having an allergic reaction to this drug, which is the same for any drug you would take. And then warnings, that's kind of like side effects. And the warnings, we'll get into the side effects of being on steroids for long periods of time. So we'll get to that. Emflaza was around in the European market for a long time before the study was done that included boys in the United States, and that was the requirement to get it approved in the United States. So the first thing I would be asking myself if I was this family is, does Emflaza work better than prednisone? Prednisone's been around a long time, and what are the side effects? And are the side effects better than prednisone? The other thing that I think is important to think about is what is the cost, although I haven't met a young man yet not worth every dollar. Fair? Agreed. But I think it's still important to note that Emflaza is 500 times the price of prednisolone syrup, at least according to drugs.com. But there now is a generic version of Emflaza, deflazacort, that's been FDA approved. We don't have the cost for that to share with you, but it will be less. So there have been several different studies comparing deflazacort to prednisone, but I'm going to focus on the more recently published and largest study called 4DMD, in which almost 200 boys between ages 4 and 7, none of whom had been on steroids before, started steroids. And a third of them were given daily prednisone, meaning every day. A third were given daily deflazacort. And a third were given 10 days on and 10 days off of prednisone, or what was called intermittent dosing. What was not studied was you doing what we call weekend dosing, which we do a lot of here. Some places do, some places don't, where you just take a higher dose prednisone on Saturday and Sunday. That wasn't studied here. And what you're looking at here, and I think it's helpful to look at these graphs, and we have a lot of graphs in this presentation. We're not going to try to get bogged down in the details, but you're looking at different functional outcomes. How fast they can, the boys could walk 10 meters, the North Star score, which is a measurement of their ability to do certain functions like get off the floor, or stand on one foot, or walk up a step, how far they could walk in 6 minutes, and then that forced vital capacity, that's how much they can breathe out, they can blow when they blow in a tube. And the red line and the blue line is daily deflazacort and daily prednisone. Daily deflazacort in red, daily prednisone in blue. And you can see as well as I can that there's no difference between daily deflazacort and daily Emflaza on these functional outcomes. And it's important to note this is over 3 years. So this is a really long time of following these boys. This was a major effort. That kind of lower line, that green line, is the intermittent steroids, 10 days on, 10 days off. And so that clearly the boys did not do as well on that regimen. There is no line here for not being on prednisone, but I can tell you that it would not look as good as the red lines and blue lines. Those boys do go downhill faster.
And they all improve a bit at the beginning, I think, is also important, which is what we see in our patients. And then things kind of plateau, and then you can see at the end of the 3-year time frame, things are starting to get hard for all of them. Harder for all.
Yeah, harder for them all. They gained about 4 points on the North Star. Each point is a functional gain, a thing they could do better than they could do before, or maybe even a new thing like walk up a step. So all these boys get better initially, and then unfortunately they continue to decline. So that brings us to the new steroid, Agamree, or vamorolone, which is what I tend to call it. And all the excitement about vamorolone is because it's called a dissociative steroid. And what that means is that in its design, it is supposed to give you the benefit of the steroid without the side effects. And so it's called dissociative because it splits the good part of the steroid from the part you don't want. That's its design. And it was approved just this past year in boys 2 years and older, same as deflazacort. It is a liquid or a suspension. You take it with the meals, and I have the dosing there for those of you that are inclined to look at it. Again, you can see it's just allergic reaction. That's be the only big thing to worry about. But there are side effects similar to other steroids, and we'll talk about that. But the first thing I would be asking is it better than prednisone? Prednisone's been around a long time, and it's real cheap. And the second thing I would be asking is, what are the side effects, and are they better than prednisone or deflazacort? And we'll compare them. There's the cost for you. The vamorolone or Agamree is about 100 times the cost of prednisone, better than the 500 for Emflaza, at least according to drugs.com. So let's say you're on steroids, which I would imagine many of the young men or families of young men listening, I would hope, are on steroids. And the question is, well, should I switch? Should I switch to vamorolone? And what I'm showing you here are the functional outcomes of exactly that. These are boys that spent 6 months on daily prednisone compared to daily vamorolone. The prednisone group is in red. And then at 6 months, they flipped over to vamorolone. And so that solid red line is the boys that flipped over to vamorolone, and the blue line are boys that were on vamorolone the whole time. Each one of these graphs is a different functional outcome. The North Star is in the middle on the right. And you can see that there is very little difference in terms of whether one is, quote, better than the other, at least in terms of the function of the boys. You agree with that, Nat?
Yeah.
Based on this information here. So if you were to say, I'm not very happy with the prednisone, I don't think my son has gotten much benefit, I want to switch to the new one, I would tell you you're likely to receive the same benefit based on this information. So what about the side effects? this is looking at height. Boys on daily steroids don't grow much taller. They tend to stay small, especially Emflaza, but also daily prednisone. The red line is changing in height over time compared to normal growth. And so you can see that boys with the red line, they don't get taller. Whereas boys on the blue, which is the higher dose of vamorolone, they do continue to get taller. And when you switch, that you tend to start to grow, which is what you're looking at the bottom. Those solid red lines on the bottom left, you can see they start to go up. Those boys are starting to grow when they switched over to vamorolone. The dark line is the higher dose and the light red line is the lower dose vamorolone. So in terms of growing taller, vamorolone seems to do what it says, which is that it is just as good as prednisone, not better in terms of getting you stronger or helping preserve your function, but it doesn't have quite the side effects of making you really short. And the reason that that's important is because we worry about bone health. Of course, I want boys to grow taller. I want them to look like their peers in terms of their size, but I don't want them to have fractures in their spine, and I don't want them to have fractures in their femurs. And so we think that this evidence of the boys growing taller suggests that maybe vamorolone doesn't bother the bones. And hopefully that will mean that they will have less fractures over time. The preliminary studies suggest that, but it's going to take a long time to know for sure that that's the case. But I think that's pretty good news. You agree?
I would definitely agree, yeah.
So let's just do a quick comparison here. As best we know, prednisone, Emflaza, and vamorolone all are similarly functional. One is not better than the other in terms of getting you where you want to be with your strength or your function. Prednisone is definitely the cheapest. It's very easy to get. You can get it without insurance approval. But it leads to weight gain, short stature. You can have behavioral problems. It delays puberty and osteoporosis, and you can get kind of a big face sometimes with it. Emflaza has similar risk, except the weight gain is better. That was why everyone was so excited about it. And that's true. They don't get as heavy, but they get more cataracts and they are real short. That's a big issue with Emflaza. And we worry about their bone health and the risk of vertebral fractures. And we've been pretty careful about Emflaza when we counsel our families about that. Vamorolone, like we showed you, those boys tend to grow. And when you look at how their bone is maturing, it seems to be maturing more normally without the impact. So I'm hopeful that those boys on vamorolone will have less vertebral fractures, which is a big issue with daily
really
steroids.
Big deal. It's painful. It really negatively impacts their life as they get older. So
now we can avoid a lot of that with weekend steroids too.
Yeah, true.
And we've been doing that for a long time, but that hasn't been part of all of these studies.
Okay, so now we're going to switch gears a little bit and talk about this newly approved medicine called Dubizat or Givinostat, which is just starting to become actually available at the pharmacy this fall, we think. It's what's called an HDAC inhibitor. I think the important thing to know is that it is similar to steroids. It's a general medicine, so it is not specific to DMD. We think how it may work and help boys with DMD potentially is that it may decrease some of the fibrosis that can happen in the muscles. It maybe helps a little bit with that piece of the inflammation in the muscles, and it maybe helps a bit with making new muscles. It was recently approved just this year in 2024. It was approved for everybody with Duchenne muscular dystrophy ages 6 and up. That doesn't mean that insurance is going to cover it for everybody with DMD 6 and up, but that's what the FDA approved it for. It was tested in boys who were 6 and up who were still walking and met some other criteria in the clinical trials. It is a liquid. It has to be taken twice a day with food. And you can see the dose range on there, which is based on weight. We have no contraindications. There is an exception if boys have something called prolonged QTC, which you can see in the warnings, which is essentially a heart arrhythmia, where the boys, it's taking a little bit longer for their heart chambers to kind of refill. And if the boys have a certain threshold for that, we could not give them this medicine. But the other warnings include low platelets, which help the blood clot. There can be high triglycerides, which is a cholesterol number, and then there can be some abdominal pain and diarrhea. This does require lab monitoring, more upfront when the medicine is starting, every 2 weeks for 2 months, and then monthly for 3 months, and then every 3 months after that.
So Nat, this is just a steroid, right? Another steroid?
This is not just another steroid. This medicine works differently, and it was studied in boys who were already taking steroids, and this is looking at kind of another pathway.
So it's in a different class.
It is in a different class.
Different class.
Yes. Okay, so here going through these questions. So does it work? And we're going to talk a little bit about the clinical trials for this medicine and what it means in a disease like DMD, where the boys kind of get slowly worse over time. What does it mean for a medicine to work? So does it mean it will make the boys better? We'll kind of show you that the boys didn't actually get better. Will it stop me from getting worse? Potentially from the data that we have, which I'm going to show. The side effects I already talked about. So you can see about a third had that low platelet side effect. About a fifth of them had the high cholesterol number, the triglycerides. Just over a third had the abdominal pain, diarrhea. And then the QTC prolongation was actually seen in healthy adults who were given this medicine at a bit higher doses. As far as I know, it was not seen in the clinical trials for the boys, but we did monitor them. You can see the cost on there. I will note that this is not 100% confirmed. We had a little bit of trouble finding the cost, but it is certainly not cheap. One bottle that's this 36,000 is expected to last about 2 weeks for the highest dose category. So very high cost medicine.
Like $700,000 a year.
Yes, exactly.
Yeah.
Okay, so this is looking at the study that I was referring to. So this was looking at boys with DMD ages 6 and up who were still walking. And at baseline, these boys were able to get off the floor from laying flat on the floor to standing straight up in less than 10 seconds. And so what we're looking at here is a change over 18 months in boys who got this Duvizat or Givinostat medicine in red versus boys who got placebo in blue on what is called the 4-stair climb. So how quickly boys can go up 4 stairs. And so what we're looking at on the graph is the change from baseline in the number of seconds it took them to go up the 4 stairs. So you can see that it took both groups a little bit longer as time went on, the 18 months. The Givinostat or Duvizat group in red, they went up the stairs a little bit more slowly, but the placebo group went up quite a bit more slowly, close to 3 seconds versus 1.3 seconds in the Givinostat group. And so this was enough of a change to be what we call statistically significant, where we think that the two groups were actually different enough. So what we would say is that this slowed the decline in the boys who got the medicine over the 18 months. And then I'm gonna look at some other what we call endpoints, where they were looking at different things in the trial to see if they differed between the two groups, the boys who got medicine versus the boys who didn't. And we go ahead and we'll show that there actually was not a change in these other tests that we did over the 18-month time frame. So we're looking here at the North Star test on the left, and the Givinostat group is the solid line, the placebo group is the dotted line, and we're looking at the change in their total score over the 18 months. So you can see that the Givinostat group lost some points as well as the placebo group. It does look like the placebo group got worse than the givinostat group. It just was not enough of a difference to meet what we call statistical significance. On the right, we're looking at the North Star test, which looks at the boys' ability to do certain things like hop, stand on one foot, stand on their right leg, stand on their left leg, get off the floor, go upstairs. And so what we're looking at there is the loss of function. So boys who at the beginning could they could do a certain activity at the beginning, and then they have lost that activity. And we're looking at the number of activities that they lost. So it does look like, looking at the graph, the placebo group lost a little bit more than the givinostat group, but again, it was not enough to be statistically significant.
Yeah, and the reason it wasn't enough is because it's a statistical issue with how many tests you are testing. The more tests you do, the harder it is to show a difference.
Yeah, the stricter you have to be in how you analyze for the difference, basically.
So we can still look at this and say, well, on average, the boys on givinostat lost about 2 skills, and the boys that were on placebo lost almost 7 skills.
Yeah.
Four
versus,
skills. Sorry, 4 skills.
7.5.
Versus 7. Yeah. So all of this favors givinostat. It just wasn't statistically significant difference.
Right. That difference in the 4-stair climb was the only thing that was actually statistically significant. So same thing here, looking at change in baseline and how quickly the boys were able to get off the floor. Again, the placebo group is the dotted line, the givinostat group is the solid line, and you can see that they are both a bit slower over the 18-month time frame. Again, not statistically significant. Placebo group took 13 seconds longer, quite a bit longer. The givinostat group about 8.8 seconds.
So the boys on givinostat over 18 months got worse.
They got worse, but not as much decline as the boys who got placebo over the 18 months time frame. Same thing here, but looking at the amount of fat that was present in the muscle. So they actually did muscle MRIs of the thigh or the quadricep muscles, and looked at how much fat was present at baseline versus the 18 months. And that is relevant because boys with DMD, their healthy muscle gets replaced by fat. And so more fat present is bad. And so you can see again, dotted line placebo, solid line givinostat. Both of them had an increase in this fat fraction over the 18 months, but more so in the placebo group, it looks like, than the givinostat group.
So the boys in this trial, they had to be 6 to get in.
They had to be 6.
So the steroid trial we looked at, they had to be 4.
Yeah, they had to be 6 and up, and then the steroid trial 4 to 7.
4 to 7.
Yeah.
So when you look at a group of boys that are 6 and over, and the average age in these studies wasn't 6. I mean, they were older than that.
They were older, yeah.
We would expect them to be declining at that age.
We would, yeah.
So the fact that givinostat seems to make them decline less over time, you think that's enough?
I think that's meaningful. Yeah, I think it's meaningful, potentially in combination with other medications.
Yeah. I think it's meaningful too, because you look at how much of a skill they were able to maintain compared to the group on placebo. I think that's a meaningful difference to me.
Yeah.
But if it's my son who's taking it, I might not be able to tell.
That's right. I think that would be the expectation. It's not like initiating steroids where you expect to see some things get better at the beginning. That's not the expectation with this. The hope is that the decline is going to slow over time, and nobody's really going to be able to know, for the most part, with maybe some exceptions.
Yeah, it'd be hard to tell one at a time.
Agreed.
Yeah, that's what I think too.
Agreed, and does require some lab monitoring, some safety.
And the lab monitoring for giviноstat's not nothing.
No, it's not nothing.
It's not nothing. And we've seen those problems with the platelets, and we've seen the upset tummy, and we've seen the triglycerides.
Yes.
And those
all responsive to changing the dose a bit, though. We went down on the dose in the clinical trials, and with maybe one exception, everybody continued, and their event resolved when we change the dose.
If you drop the dose, they get better.
Yeah.
But those triglycerides are a pain in the bottom to check because
Yeah.
you can't, if you had a big lunch and you check your triglycerides, they're going to be through the roof.
Right. Yes. Better to be fasting, which is hard, and the little boy going to school and mom and dad are working. Yeah. Challenging.
Yeah, challenging.
Yeah.
All right. So we covered sort of those two categories, the steroid categories, now the HDAC inhibitor, this antifibrotic, and now let's get into the genetics of it, which is, I think, what most of you are probably waiting for. Well, these other things are pretty cool.
Yeah.
So let's just review the structure of the dystrophin gene here. This is what we call an exon map of the dystrophin gene, and you can see that they have different shapes on it. And the reason that's important is many young men with Duchenne have a deletion or a duplication of some of these exons. And if the way in which by chance they happen to delete or duplicate them kind of messes up this pattern where some fit together, if you take some of them out randomly, it won't fit together again. And that's just saying that mutation is what we call out of frame, which means that you can't make the protein from the beginning instructions, number 1, to the end instruction, number 79. And the most important part, we think, of the dystrophin gene is having the beginning part and the end part. A lot of the middle part is like the spring. But the Velcro stickies are at the beginning and the end. And if you don't have the Velcro sticky, the protein doesn't stick where it's supposed to, and it doesn't connect, and it can't do its job. That's kind of how we think about it. At least that's how I think about it. So we gave a little example of these boys that were missing exon 52. And you can see here, if you're missing exon 52, exon 51 can't connect to 53. This is what we call an out of frame deletion. And one way to repair this is, instead of trying to stick 52 back in there, you can see if you can actually get rid of 53 or skip exon 53, 51 can connect to 54, and you can at least continue making protein so you can make it all the way to the end. And we call this exon skipping, and this is, believe it or not, old news.
Yeah.
But we wanted to make sure we talked about this. It makes a shortened version of the dystrophin protein because the part of the protein encoded by exon 52 and exon 53 will be missing. So it won't be the perfect protein, but we think it would be better than nothing. So there are 4 currently approved exon skipping therapies. There's eteplirsen, golodirsen, I have it written wrong, casimersen, right? Is that what it is?
Oh.
Yeah, I have it. Sorry. And vitilarsen. Sorry, I have it wrong there. Despite reading this 100 times. Sorry, everybody. The idea here is awesome. And we think the idea here is very powerful because you can make, depending on the deletion that you have, you can make potentially a nearly normal protein. Depends. If you have a large deletion, then you'll have a smaller protein. But the problem with these medicines that are approved is that they just don't get in the muscle fiber. And so the muscle fibers, they only produce about as much as 5%. A lot of these only make 1% of normal dystrophin. Now, that's a lot more than these boys with DMD are making because they make almost nothing. So when you are reading about these, oftentimes this information is presented, it says, well, you'll make this many times more, 10 times more, 100 times more, but it's 100 times more of almost nothing. Right. So it's still not near what a normal amount of dystrophin would be.
And they have to be given weekly IV. So it's a big
big deal.
Yeah.
So it's the beginning of what we think is going to be something better in the pipe. And there are a lot of medications in the pipe that use the same idea, but are just trying to improve the delivery of these exon skipping medicines to the muscle fiber. And so we are looking forward to the next generation of these, aren't we?
Absolutely. Not just for the effectiveness, but also a lot of them are only given once a month or every 6 weeks or every 2 months even, which I think would be great for our families and boys.
Yep,
So,
but those are in clinical trials.
in clinical trials, yeah.
And the hard part about being in a clinical trial is a lot of the clinical trials say you can't be on these to start with. And some of them
Can't
say
be on these approved ones
these approved
to get
ones.
into the new trials. True.
Yep.
Yeah, we fight that every time we talk to a company.
Yep. But you understand why they want that. They want boys that haven't seen these other drugs. So we've had a hard time with that, haven't we?
Yeah. So why can't we just give these boys, just replace exactly what they're missing? Give them a new DMD
give them the
gene.
new gene.
Yeah.
Well, we can't give you the new gene, at least not yet, and that's because the new gene is way too big. It is the largest gene in the body, and we can't package that and deliver it. We don't have a way to do that yet. So you can see this is a cartoon of what a normal dystrophin looks like, and there happened to be a 61-year-old man who was still walking, who had a very, very large deletion in his dystrophin gene.
Still walking in his 60s.
And walking in his 60s. And so that gave people the idea and some information about which parts of the protein might be most important. And that's where this idea that the beginning part of the protein and the end part of the protein are the most important. And if you lose some of the spring between the Velcro, then it might still give you a big bang for your buck.
Right.
Now, what's important to know about this guy with Becker muscular dystrophy is he doesn't only make a really, really small dystrophin protein. He makes a really small dystrophin protein in every single muscle fiber. And what we are trying to do is we are trying to give instructions to make a very small dystrophin protein. And you can see that there on the right, but it's not exactly the same. It's even smaller. And it isn't going to get in every single muscle fiber, at least not yet. That's a big ask. How do we give it? Well, you package it in a virus. And we talked about this last year. So for those of you who are back, welcome back. You package it in a virus. That virus doesn't contain the parts of the virus that get you sick with the common cold. It just uses the envelope or the vector of the virus to sort of deliver it. And instead of having a package inside it that makes you sick, it has something inside it that we think might make you better, that we put in there called a cassette. And that cassette contains this transgenic material. And there's all sorts of new ways of people trying to do this that are in development. So this is the idea behind delandistrogene moxeparvovec, or what we're going to call Elevidys. That's hard to get out. Yeah, thanks. So, and it makes this microdystrophin. So some of my families, when they come to meet me, they are under the impression that it's exactly the same. It's the missing gene is what people say. It is the missing gene, but it's only a very small part of the gene that's missing. And it's important to understand that this does not get in every muscle fiber. It gets in somewhere between 20 to 50% around there. It's varying outcomes. And it was been approved by the FDA initially in 2023 and then expanded in 2024. And it's now approved for boys with Duchenne age 4 and over. How was it approved? It was approved in ambulatory boys based on their clinical benefit. And it was approved in non-ambulatory boys based on the hope that it will benefit them. And we don't know yet. It's a single intravenous infusion. And there are some kids who can't get it. If you have exon 8 or 9 that are missing, we won't give you this. And it can cause a number of different side effects, which we're going to get to. So does it work? What are the side effects and how much does it cost? It costs over $3 million. And every one of those boys out there, they're worth it. But I don't know that you're going to get $3 million worth of cost savings in your healthcare for this. This clinical trial did not meet its primary endpoint, meaning that boys on the North Star, on average, between ages 4 and 7, on average, they did not get more better than boys that got placebo. But they did get faster. So they didn't gain function, but they got faster getting off the floor and they got faster going 10 meters. And you can see that data here. And you can also see that data here. This is the North Star. The middle group here, the middle graph, those are the 4 and 5-year-olds. And you can see the 4 and 5-year-olds, the purple line that got the drug, they did get more function. than the boys that got placebo. They all got better. But the older boys, the 6 and 7 on the right, they're exactly equivalent.
Right.
And when you add it all together, it didn't. One kind of washed out the other, and it didn't meet its level of significance. But because of this, the FDA approved it for 4 and 5-year-olds.
Right.
This is how fast they got off the floor, and you can see the 4, 5, 6, and 7-year-olds maintained their ability to get off the floor, whereas the placebo group didn't do as well or went downhill. And this did meet its endpoint, but this wasn't the main design of the study. And this is how fast they went 10 meters, and the same thing. The older boys stayed the same, where if they got the drug, whereas the placebo group went down. The younger boys actually got faster. So we tell people that they might not get more if they are having trouble getting up, going up the steps. They might not get better going up the steps, but people do notice that their children get faster at the things that they can do, and we've seen that.
We've seen it for sure.
Yeah.
Okay, so this is to just briefly review some of the clinical trials that have taken place or are ongoing for this medication. So the first two that I have listed, that 103 and the 301, were the ones that were submitted to the FDA to kind of recently expand the label so that we can prescribe this to anyone with DMD ages 4 and up. You can see the 103, all of the boys in that medicine in that trial got the medicine, so there was no placebo group. And there's all different cohorts for what the boys kind of had to meet. So there was that 4 to 7, but there also were some older boys tested, just not very many, and not versus a placebo group. 301, that's some of the data that Dr. Zaidman just showed. This 303 trial, the third big bullet point, is ongoing. That's looking at older boys who are still walking, so older meaning above age 7, so age 8 and up, and non-ambulatory boys, primarily ongoing in Europe. I believe that they did dose around 20 boys who are non-ambulatory in the US, and then primarily that study is now ongoing in Europe. And then you can see the other studies that took place in nationwide Ohio specifically before the trials opened up across the country. So this is looking at the evidence that we have in those small cohorts of patients who are older than age 7. So we have 7 boys who are still walking when they were dosed with Elevidys who were ages 8 to 17. These boys started producing the microdystrophin in their muscles, about 12% change from baseline. And then again, there's an ongoing trial looking at boys in this age group outside the US versus a placebo. And so to kind of sum all of this up over both 1 year and 2 years, the boys in this age range all got worse on all of the measures that they looked at. The North Star, how fast it took to walk or run 100 meters, to walk or run 10 meters, to go up 4 stairs, to get off the floor. And then on the very last thing is the PUL, which is looking at the arm strength, which is important in these boys as they're getting older. They got a little bit worse over the 1 year mark in that, and then lost about 2 points by the time the 2 year mark came around.
So we have to wait for the results of the placebo-controlled trial to see if this is different than the kids that got placebo.
This is a really broad age range. I don't know, if they were mostly towards the 8-year-olds or mostly towards the 17. It's really, really broad with no placebo. That's right.
Yeah, but this wasn't a home run.
This was not, no.
Not a home run.
Similar, this is looking at the evidence for Elevidys that we currently have in non-ambulatory individuals. So a total of 8 patients, 6 in one cohort of that 103 study and 2 in another cohort of the 103 study. Relevant to note, all of the non-ambulatory patients who've been given this medicine in any clinical trial to date had to have a certain ejection fraction, a left ventricular ejection fraction that basically tells how well the heart is pumping. Their heart had to be pumping pretty well to be able to get this medicine, and they had to at least be able to get their hands to their mouth. So weaker children were excluded, and those who had heart problems significant at baseline were excluded. You can see for the most part, boys on this PUL test, the test of their arm function, they got worse over 1 year and 2 years. They did have some of the protein in their muscle though. So this is just very quickly to note that there was a similar study ongoing from a different company called Pfizer. And you can see briefly on top that is the protein that Dr. Z reviewed at the beginning. We're trying to make this dystrophin protein from this individual with Becker on very top, and that's what his gene looked like versus the second thing here is I don't think you can, you can see the full length dystrophin. This is Pfizer, which looks pretty similar to how this individual's structure of his gene was versus Sarepta's that is now approved. This one from Pfizer failed to meet all of the outcomes, and now they are no longer testing it in any clinical trial. Very tragically, one older boy passed away, got very sick within a week, is my understanding, after getting dosed with a heart-related side effect, and passed away after getting the Pfizer gene therapy medicine.
There haven't been any deaths associated with Elevidys that we're aware of.
That's
is that
correct? Yep. Okay, so this is looking overall. I think the take-home point for this is that there's a lot that goes into the care both before and after for getting gene therapy in a boy with Duchenne muscular dystrophy. We have to, at baseline, check lots of labs and make sure that they are healthy enough, that their heart is healthy enough. And we have to start them on everyday steroids starting a day prior to the infusion. In general, we have to do prednisone for that, even if boys for their DMD are on a different steroid. If they're on Emflaza or they're on vamorolone, they generally have to take a fairly high dose of prednisone for a couple months after they get this infusion. They have to get labs weekly for about 3 months. Oftentimes, we have to repeat a lab, sometimes check labs every 2 weeks. Sometimes we have to give even higher steroid doses. And sometimes we need to see a boy pretty urgently if something is abnormal on their labs. So families and the boys have to be pretty available for the time frame pre and post dose, especially the first 3 months after this is given.
So we won't give this to a family that we can't get a hold of.
That's right.
Yeah.
For the child's safety, it's and we're going to show some of the side effects, the reason behind that. This summarizes, I think, what I've already said. Only other relevant thing is that we don't want boys to be sick or to have had a vaccine within a couple weeks of getting the infusion. The boys have to stay on site. At our site, we have them keep them a couple hours. Some sites may keep children overnight, actually.
And for the older boys, maybe longer, because we're kind of winging it.
That's right. And so if this is just a one-time infusion, why can't the children just get the infusion and be done? Why do they need all this other stuff? And this summarizes the reason for all of the follow-up, why we're not just following them that day that they get the infusion. They can have an allergic reaction actually during the infusion. That's rare. But most of the side effects come later, as far out as a couple months after the infusion is given. And you can see the progression. So a handful of boys have had this serious myocarditis side effect within a week or so after the medicine was given.
Heart inflammation.
Which is heart inflammation. Most common, I would say, more severe side effect is over there on the right, a couple months after it's given, is this acute liver injury. So we would really suggest that there be an experienced care team to monitor the boys and manage these potential side effects after. It does take some experience to know what to do when a side effect happens.
Let's skip the next slide, I think, Nat.
Yeah. Okay, yeah, too much detail.
Yeah.
Okay, so going back to these two brothers, ages 4 and 17, what should they do?
Well, maybe we should turn it over to questions from the group at this point.
Agreed.
But and hopefully we didn't overwhelm all of you. We talked about how to put this talk together. We want you to know what we know, and here's what we know: vamorolone, Emflaza, and prednisone, they work similarly well. They have different side effect profiles. The Givinostat or Duvizat, it doesn't stop this thing, but it looks like it slows it down. And even though it was a lot of these secondary outcomes, I was pretty impressed that they were meaningful.
Agreed, yeah.
In terms of what we could expect.
They were all pretty consistent.
And pretty consistent. Yeah. Every one after the other all showed sort of the same thing. But if I started this medicine and someone says, I don't think it's working, I want you to raise the dose, I don't know how I would know. These are average decline, and each boy changes differently. And then this Elevidys business, with it being approved for all of these non-ambulant, for basically any age over age 4. Boy, I'm nervous about that. In some of these much older boys, there's a lot of risk to the heart function. And if you get that inflammation in your heart, it doesn't necessarily come back. And I don't know how much better we can expect these boys to get. And there has to be enough muscle there for this drug to get into it, to work. Yeah. And, this isn't the kind of thing I can give and then stop it. Once you get it, it's in there.
It's in there. We just have to manage the side effects. And it was never tested in anybody with a real sick heart at the beginning. Yeah. They had to have that ejection fraction be 40% or higher.
Yeah. So. And I'm hoping that, I'm excited about this. I really am. And we're giving all of these drugs. We're prescribing them. But we have a really long talk with our families about each one. They have to be informed. They got to be cooperative and agree to all of the monitoring. And we're hoping that there's going to be something better in the pipe. These exon skipping drugs may be the next thing. I hope better so, exon skipping. Yeah. All right. We went right up to time, but we can hang for a little bit. I'm going to come back over to where I can see everybody. Hopefully you're still there. Is everyone still there?
Probably not everybody.
Marissa?
Sorry, I couldn't find my unmute button, but we are absolutely here. And thank you so much. I really like how you laid that out for us, and very informative. Tons of questions coming in the chat.
We couldn't see the chat while we were talking. I'm sorry, everybody.
No, that's okay. We were monitoring it. We were answering things somewhat as we can. I will say, we get a lot of questions about very specific diagnoses, and we can't unfortunately answer all of them on this call. Just a plug for our next webinar. We will be talking more in depth around gene therapy across neuromuscular diseases. But in general, can you speak to how some of these advancements in gene therapy are transferring over to other advancements in other diseases, and maybe where the correlation is, not just like beyond Duchenne?
Yeah, sure. I mean, the anti-fibrotic medicine, that could be applied to other muscular dystrophies. That doesn't have to be Duchenne specific. The technique for giving gene transfer therapy can be used to deliver other genetic payloads. And some other disorders have very small genes that are missing and theoretically could have the whole gene replaced. So we are already, even before Elevidys, we've been doing gene transfer therapy for spinal muscular atrophy, for instance. So all of this, I mean, this is all good news. We put a lot of color in our talk because we want to set the expectations. But this is all good news for not just Duchenne, and this is good news for other genetic diseases of muscle, and we already have FDA-approved treatment for genetic diseases of nerve for spinal muscular atrophy. So, I mean, I hope I'm around long enough to see it, and I hope so is everyone on this call and all their boys. I'm hopeful. It's coming, and this is the beginning. I'm really excited about it. I see one of the chats here about an 18-year-old with a nonsense mutation, and is he a candidate? You can have a nonsense mutation and be a candidate. You can't have a deletion of exon 8 or 9. So if your deletion goes from 4 to 20, you're not a candidate. If you have a nonsense mutation, you are a candidate for Elevidys. Boys, I think up age 20, 21 have been treated with this. Do you remember the oldest boy?
I think it's lower 20s.
Lower 20s.
Accurate, yeah.
Yes. So yes, the conversation that I would have with this 18-year-old is, what is this 18-year-old's level of function today? And is it worth the risk? Because I don't know that there's going to be much benefit. We don't know. And we could guess. Depends on his level of function.
Right.
And how much muscle he's still got at age 18. I hope a lot, buddy. I hope a lot.
For sure. Are there any options for using a bigger virus or something, or the option to package the whole gene to make gene therapy easier to deliver?
Don't go too deep in it.
But not necessarily to use a bigger virus, but they are testing different vectors that are not viruses that potentially get into the muscle a little bit better than viruses do, and maybe will have less side effects, less of the heart side effect, less of the liver side effect, because the virus can be, or the vector rather, can be not get into those places as well. They can kind of select where they want it to go. And then the other thing that they are testing in mice is actually using more than one vector to deliver different pieces of the gene, which then kind of hook up once they get into the body and can maybe even make a full-length dystrophin protein. I mean, that has been tested in mice. So a little ways away, I would say, and potential for more side effects.
Some of the other questions that are coming in, Marissa, I'm fielding here to keep things moving. I hope that's okay. The two important questions. One is, can you give it more than once, or is there a way that we could dose a boy that has antibodies against the virus? And that there are several different clinical trial approaches for that, including giving a medication to try to reduce the antibody amount, or washing the blood, or doing what we call plasma exchange. And those trials are either just started or starting. And so people are thinking about that. It is theoretically definitely possible that we can reduce the amount of antibodies and potentially safely administer this. And that might allow even for redosing. So that is a theoretical possibility. The other question here is, what if you don't have a deletion in exon 8 or 9, but you're close to it? And the answer is that if you have a deletion that includes any of the genetic material that we are giving, there is a risk you will attack the new protein. And so that is a risk we are aware of, but we are learning in real life whether that risk is high or low. It seems to be low. And many children all around the deletions of 8 and 9, and some children that have deletions in 8 and 9, have gotten this drug and have not developed what we call immune myositis, where their body attacks the muscle, which will actually make you weaker. But we have had 2 boys who have had it, so we're pretty aware about it.
And then the other thing that I saw is inquiring about long-term studies of looking at Elevidys, more than just a year, which is what we presented, or 2 years. And there are studies that are ongoing looking at those original patients who got the medicine in the clinical trials. I would say, you think I can share our inclination of how our boys are doing?
Let's first say that there are the first 4 boys to get this have data published following them out 4 years and showing that they have remained similarly stable. And there is also longer term safety data related to long-term safety effects that have not revealed any late or long-term consequences. So the safety data that we showed seems to be within the first several months of getting this, without much, years later. We have seen, what are you showing me, Matt? Sorry. We have seen boys continue to show signs of progressive Duchenne muscular dystrophy after getting this medication. That's been our personal observation, and we will wait to see whether that's true among larger groups in these larger studies. So our observations have been that over time, these boys that got this drug don't just lock in. They do decline over time, and we counsel our patients about that. Go ahead, Nat. What are you gonna say?
I was just going to say, with still an unknown as to how they would do, if they had not gotten the medicine. So we're starting to see them have some challenges a few years out, but we don't know, what they would have been like if they had not gotten the Elevidys.
And that observation gives me pause when we're talking about treating what we would call late non-ambulatory stages of disease. Boys that are old enough or severe enough that have just really function limited to their hands, I would be cautious about treating that group personally.
Yes, because of the potential for side effects. It's not,
It's not risk-free.
Right.
Not risk-free. We'll take some more questions. I mean, I got time.
Sure. Yeah, we can do a couple more. We do want to be cognizant of everybody's time.
Well, they can drop out. We got to sit here.
This is true.
Marissa's day might be
Marissa, you
down,
might have
though.
things you need to do.
No, definitely not for me. More want to make sure our interpreters are able to continue with us.
Thanks for the nice
question for you.
comments in the chat there. Thank you. keep them coming.
You guys are fun. A question that came in earlier is Duvizat. I'm sure I said that wrong. My pronunciation skills.
No, you did it right.
That's right, we think.
Okay. Is it recommended in combination with steroids and or post Elevidys dosing?
All of the studies we showed you for Duvizat and for Elevidys, and we didn't show you the exon skipping, all of the boys had to be on stable doses of steroids prior to entering. So all of that benefit or stability, all of those children were taking steroids and on stable dosing. In terms of whether we think you can combine all of these, each of these drugs works differently. And in my mind, you go for it. I think you can use them all. But each person has to be a candidate, and I wouldn't start each of them all at the same time. Each one in order, because you can have side effects to all of them. And I don't know that they'll get paid for. But we we've started boys on exon skipping after they've gotten Elevidys. We are prescribing vamorolone in children who've gotten Elevidys. We are now prescribing Givinostat in children who've gotten Elevidys, because we are seeing them manifest signs of Duchenne, and we want to help them.
And they work in different ways.
Yeah, they work in different ways.
Yeah. How does Agamree versus prednisone compare when it comes to bone density and the Cushingoid appearance?
Less Cushingoid appearance, but they still gain weight. And the way the Cushingoid appearance, sorry, Nat, go ahead.
No, you're
the way the Cushingoid appearance was assessed was slightly different. So you're comparing some natural history studies to the other, but vamorolone seemed to be a little favorable, but to me, the most impressive data was the height. And that's why we focused on that.
And then the bone density, I don't think we have direct bone density. Like, I don't think they did bone density scans. So we're inferring that their bone health or bone density probably is better on Agamree versus prednisone because they grew taller. And then there also are some blood tests that show, new bone being created essentially that looked better on the Agamree patients versus the prednisone. So we hope that their long-term bone density will be improved.
They did look for fractures with x-rays. I don't remember if they did DEXA scans. There's a lot of supplemental data in there. They might have done DEXA scans. I'm sorry. I don't remember off the top of my head the bone density specifically. They did look for what we call occult fractures and are counting fractures, and the vamorolone group did a little better than the other, but there were very few fractures in all the groups.
And then the question too about the boys getting taller, the center of gravity gets a little higher, so the impact of falls may be more significant. Is that correct?
I don't think about it that way. And the few studies looking at height on the impact of people walking suggest that actually your height doesn't worsen or help. We used to think that maybe boys that were shorter could walk better, but the little bit of study that I'm aware of didn't demonstrate that even as you get taller, you still can walk well. So I'm not 100% confident about that answer, but that's my best guess. You agree with that?
I would agree with that. Yeah, for sure.
All right, maybe two more questions here. Is there a way? Oh, go ahead.
Are you reading the sirolimus question and the
Yeah, but feel free to, if you want to read that and address it.
The immunosuppressive regimen has been different in different studies, and so in terms of standardizing it, I mean, we are in the many devoted clinicians I mean, we had a meeting yesterday that neither of us could go to, unfortunately.
Yeah.
I mean, we are working on trying to come up with some guidelines for how to do this so that that those of you out there that don't happen to live next door to us or many other wonderful centers around the country can get this done safely. I think that's the main. That I can't really comment specifically about sirolimus, tacrolimus, or eculizumab and prednisone and all of that. The Sarepta studies just required stable dosing of prednisone, and then you had to go on an additional daily dose of prednisone prior to and continue for essentially 3 months. You taper off during the last month. And that's very similar to what we do with Zolgensma, and other trials have more requirements in terms of what they're using for their immunosuppressive regimen.
Which we think is probably more so due to the side effects of the vector and not necessarily to improve the effectiveness of the medication.
Yeah. Hopefully these new, what are they called? The specific vectors they're making? The engineered vectors will require even less immunosuppression. That's the idea. These engineered vectors might not trigger the cascade of your body attacking it.
Thank you, Mr. Tengsali. Nice to see you.
Two more questions that I wanted to get to. We've had a fair amount come in about, are any of these drugs in general beneficial for Becker? Just because Becker and Duchenne are somewhat related there. Do you see any of the drugs you talked about being beneficial for Becker, or how that translates?
There was a Duvisat trial for Becker muscular dystrophy, which did not meet the endpoint, so it did not appear. And while in theory it might be beneficial, the trial that was done, it was not. The other question, I guess, would be probably related to steroids. My understanding is that there's an ongoing vamorolone trial in Becker. Does that?
I'll take your word for that.
But to date, prednisone, for example, has not been shown to be effective in Becker muscular dystrophy.
It's hard to study Becker muscular dystrophy because the natural history is even more variable than Duchenne. So we do prescribe steroids for patients with Becker that we think are declining. We don't know. We don't have the information to promise that it will work. So we mostly have a conversation about unknown benefit versus known side effects. And you can hear that's very similar to where we're at with some of these new medications. Unknown benefit, known side effect.
All right. Well, I think maybe just ending with one question is, how can patients and families get more involved to kind of move all of these different trials and possibilities along faster? Is there anything they can do?
Well, the MDA has a long track record of advocating for patients with relatively rare disorders, including Duchenne muscular dystrophy. And amazingly, the MDA manages a lot of other disorders as well, including these even ultra rare limb-girdle muscular dystrophies, and even as far out there as Lou Gehrig's disease. So I think participating in patient advocacy organizations like the MDA, and there are Duchenne specific advocacy organizations as well. I mean, that is the way to do it, I think.
I would totally agree. And if you wanted to search for clinical trials for your specific disorder, you can go to clinicaltrials.gov and try to email the company or the site directly as well. And
you can contact your MDA representative and they can help you navigate this. And if you're lucky enough to work with Natalie, then she'll help you. And she does do that for a lot of people, including people we've never met. Sorry, Nat. I've opened the floodgates. Natalie will help you too. We care about you guys. We really do. We care about each and every one of you. I'm really looking forward to the next great thing. but we got to go with what we got right now, don't we?
That's right.
And we're here to help you do it.
Well, it's very obvious. It came across very well how much you care and the investment that you have in the neuromuscular community. So thank you both very much for preparing and giving your time and your expertise to this. We appreciate it. We also just wanted to share that we do have our gene therapy support network. We launched this just over a year ago. We offer on our website educational materials, both in English and in Spanish. And also we have opportunities that you can set up a video call one-on-one with a gene therapy support specialist to get more information and to kind of help guide you on what's out there, what's to do next, how to talk to your healthcare provider, all those kinds of things. We also provide some clinical networking for professionals as well. So we encourage you to scan the QR code on the screen or go to the link in the chat and check out some of the materials. We also have a self-guided learning module that you can take and just learn more about the process as well as the research.
Marissa, thanks for inviting us.
Of course. We had to have you back after last year. You did such a great job. So thank you. Thank you both. We also wanted to invite people to join MDA community groups. These are somewhat new, but there is a group offered for parents and guardians of kids with DMD or SMA that are in that gene therapy process. We also have an adult group, pediatric group, and an ALS group. And again, just want to invite everybody to join us next week and the week after for part 2 and part 3. We'll be covering insurance. Dr. Byrne will be here to talk about gene therapy across all different types of neuromuscular disease. And then the following week, we'll get to hear some information about what to ask your provider and also hear from some families who have gone through the gene therapy process. So just put this up here too. We will be offering Spanish interpretation again for those sessions. So we hope everyone will join us and spread the word. And then just lastly, join the MDA community. It'll help you stay in up to date on research, clinical trials. You'll get Quest magazine and just opportunities to connect. So with that, please take our survey at the end of this webinar. It'll pop up right as you close out. If you need additional information, you're looking for resources, we didn't get to your question, please give us a call or email us, and we want to hear from you. And thank you again for being here. And thank you, Dr. Zaidman and Natalie, and I will get your name pronounced right.
Sorry, Marissa. Had to
both so much for being here and for your expertise today. And thank you to all of those who have joined us and for our interpreters as well. We hope that this was helpful, and we wish you a great afternoon and evening. So thank you.
Bye, everybody.